third in the series of the four women's health webinars, which are brought to you by Healthy UCD and UCD Culture and Engagement. I'm Maria Heffernan from Healthy UCD. The topic this morning is menopause. Please use the Q&A function in Zoom if you have any questions as the talk progresses. And I'll now hand you over to Professor Patricia Fitzpatrick, who will introduce our speaker for the morning.
Morning, everybody, and thanks for joining us this morning. I'm really pleased to introduce Dr. Deirdre Lundy. Deirdre and myself were in UCD medicine together many moons ago, so delighted to have her here. She's a recognised expert in the menopause. I mean, the menopause is something that hits all women at some stage in their lives, but it doesn't not get the coverage it deserves at the moment, although that's starting to change, and I'm delighted to have Deirdre here. Deirdre is a GP in the Bray Women's Health Centre, and she's in charge of GP training in sexual and reproductive health on behalf of the Irish College of General Practitioners. She's listed as an expert with the British Menopause Society. She advises GPs throughout Ireland about all aspects of reproductive health, including the menopause. So I, for one, am very much looking forward to her talk. I've heard her talk before, but I'm very much looking forward to this, and I hope you all are too. Thanks very much, Deirdre. Over to you.
Oh, that was lovely. Thank you, Patricia. I enjoy talking about this, and I almost enjoy talking about it more to big groups as opposed to individuals, because, you know, the pressure on me to fix someone's problems and listen to someone's problems, it's actually quite enormous. And those of you in clinical health care, you know what that's like, because it's so much more enjoyable sometimes to kind of go through these concepts in an academic fashion, because it just lends itself better for engagement, you know. So I hope you can see these slides that I put together for today. Let me know straight away, you girls, if you can't, obviously, because that's a disaster. So I want to do some basic stuff first, because there's a lot of confusion, I think, over terminology. A lot of people don't really use the word menopause the way it's meant to be used, which is perfectly reasonable, because even clinical doctors, clinicians don't really understand what's going on in some cases. So basically, the ovaries are an essential part of a person's body. Like, obviously, from a reproductive point of view, they're in charge of housing and then releasing all the eggs we'll ever use in our lifetime when it comes to trying to get pregnant. But they're also the source of a variety of hormones, many more than the three we're going to talk about today. But the three essential ones are estrogen, progestogen, and androgen, testosterone. There's three different types of estrogen molecules released by the ovary. There's only one kind of progesterone molecule released, but there's actually four different kinds of androgen. And it's a very complicated orchestral sort of a music that the ovaries are in charge of. And what happens is, as you get older, as you first go from childhood to puberty, and then from puberty to mature reproductive years, and then from there to menopause, everything basically changes, you know? So just like a person with testicles produces less sperm and become less fertile as they age, although that never stops completely, women with ovaries, people with ovaries, start to lose ovarian function as they age. And generally in your 40s, early to middle 40s, 50s is around the time that you typically identify that. Sometimes it can happen much, much younger, which is heartbreaking and quite dangerous. Sometimes it can actually happen a little bit older, which is perfectly fine, you know? So as people with ovaries age, they start to lose their ovarian capacity for egg release. Their fertility starts to decline. We all know about that. But they also start to experience derangement in the normal musical fashion in which the hormones are released. And the derangement in hormone release is where the symptoms come from. People with no hormones eventually kind of settle down. Now, some symptoms never go away. Some symptoms persist right into the 70s, 80s, and beyond. But for the most part, the worst of the symptoms of the menopause happen not because you don't have enough estrogen, progestogen, testosterone, but because the levels start to become fluctuant and chaotic. So the concept of menopause care is to try to dampen down that up and down, peaks and troughs behavior that the ovarian hormones go through around this time of our lives. That's not the menopause. That should be identified. We call that the perimenopause. So you're not without periods. You're probably still getting quite regular periods, but your hormonal symphony is starting to get very, very noisy. And these are the symptoms that they typically produce. Now, not everybody gets symptoms at all. Some people get all of the symptoms, and how severe will vary. I've had women who have had a collection of these symptoms almost immediately when they got into the perimenopause, and then after 3 or 4 months, they just disappeared. And they thought, what the heck was that? I hope that never happens again. But unfortunately and inevitably it will. So it's a kind of a stop-start process for a lot of people, which I guess makes it harder to diagnose in some cases. So everyone knows about flushes and sweats, and we kind of joke about them a little bit. And the old witchy lady there is a bit of a caricature of a menopausal woman. It's actually quite debilitating. If you're woken up 3, 4, 10 times a night, dripping wet, you don't usually wake up when you're hot. You wake up when you've kicked off all the blankets and you start to shiver because you're now wicking the sweat off your dripping wet body. You've knocked all the covers off and you're woken from a sound sleep. And when that happens over and over again, it has enormous impact on your functionability, your daytime production, not to mention mood, well-being, chronic tiredness and exhaustion. Like that in itself is a really debilitating symptom. So we focus really hard on decreasing them. Things that have got collagen in them really rely on estrogen for integrity and support. So anything with collagen, that skin, hair, muscle, nails, soft tissues, connective tissues will all start to decline as estrogen levels become initially fluctuant and then depleted, and so on and so forth. The decrease in metabolism is the most heartbreaking one in that there's very little you can do about that. I don't know why. I presume it's some kind of anthropological slowdown mechanism, but as women age, probably men too, their ability to burn calories is diminished. So most people will gain between 1.5 stones between their 45th and their 55th birthday, unless something radically changes. And usually that's because you're eating less food as opposed to doing more exercise. Some people go through symptoms of the menopause that are actually more typical of premenstrual syndrome or PMS, PMDD. They're a rare subgroup of people, but that does happen as well, you know. Now, this is a normal process. It is normal for us to age beyond our reproductive capacity. It is normal for our ovaries to shut down and basically become inactive at some stage. What's not normal is for us to live 50 years after that happens, because typically, say 2 generations ago, human females would have died very quickly after losing their reproductive capacity and their ovarian hormone function. But now, because we're extending our life so long, many of us are facing as many years after our hormone loss as we did before. So we're really focusing on improving morbidity, mortality, and quality of life for people thereafter. And that's a slide looking at the life expectancy. The age of the menopause hasn't actually changed significantly. It's that we're living longer, you know. With regard to the workplace, because I thought this would be applicable for UCD, they reckon in Ireland there's over 300,000 women between 45 and 64 in full-time employment. And so many people have told me during clinical, you know, consultations that they've either had to downgrade their job or leave work or change jobs because they found that the chronic sleep deprivation, the lack of sort of flexibility by an employer when it came to working under certain circumstances. Now, things are a little bit better nowadays when you can work from home, and many people can, but not everyone can, you know. So in Northern Ireland, the ICTU did a survey of people in the workplace. They said that 28% of women surveyed said that when they mentioned that they were going through some kind of menopausal issue and they needed a bit of flexibility at work, that they were treated quite negatively. And that's really unfortunate. There should be some kind of menopause understanding. You don't necessarily have to have a protocol or a procedure, but everyone should know what it's about, how unhealthy, how disabling it can be for women, for people going through the menopause, and have some kind of policy in place just to have a discussion, if nothing else, not in a derisory way, you know. So what can you do for yourself or for your patients if you're a clinician during the menopausal transition when you're going from having full reproductive capacity to having no reproductive capacity? Well, if you've never considered optimizing your own personal health before, now is a very good time, okay? Loads and loads of over-the-counter products are advertised. Some of them I feel are a little bit on the exploitative side. You know, if you have a very restrictive diet and you're vitamin deficient, you should take vitamins, but no clinical evidence has ever shown that any kind of special multivitamin aimed at menopausal women has measurably improved symptoms. I mean, everybody gets a little bit of a boost when they start a new therapy, even if it's an empty placebo pill, because we're optimistic about it. But we've never seen any benefit from multivitamins over that placebo response in clinical trials, you know. And for the most part, if people are going to look for help and care, it's going to be in the menopausal kind of world, in the prescription world, but that doesn't mean that that's for everybody. So you have to have options. With regard to your diet, common sense prevails. You obviously have to stop eating processed food or minimize processed food. Excessive amounts of red meat and simple sugars and simple carbohydrates are going to plow down with regard to you trying to optimize your weight during the perimenopause. All people who live on this island need vitamin D. We are living in a tunnel, as you can see out the window today, and certainly in the winter months, you need at least 400 international units a day. It's a pain in the neck to have to take daily vitamins if you're not in the habit of doing so. So a lot of my patients enjoy and benefit from using a once a month vitamin D dose. So they're very handy. I leave them on the kitchen table on the first day of every month. And I'm like, everybody take a vitamin D, and that's it for the calendar month. It's brilliant. Calcium, on the other hand, you're much better off getting from food if you can achieve that. So if you're not just restricting dairy, chances are you're getting plenty of calcium from your dairy. But if you're not, obviously, you should look at taking a low dose calcium supplement as well. We don't like excessive supplements in any regard because they can be a bit of a J curve, improve, 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 and then decline with excessive use. Exercise is key. Exercise has been shown to decrease premature loss of life. It prevents heart disease and diabetes and a variety of other problems and issues. With regard to bone and muscle, which we really are vulnerable in as women as we age, estrogen is the main driver for osteoblast activity. So when estrogen levels become fluctuant and then fall off, you get this derangement of bone coupling. So osteoclast activity, they're the cells that suck bone out of the cortex, become excessively active. Osteoblast activity slows down. So we get a net bone loss, that's osteoporosis. And we're much more likely to fracture as a result of that. Now, people are not afraid of fractures the way they're afraid of cancer. They're like, oh, I break my leg, I break my hip. Fracture for older women is usually a life-ending event. About 1 in 3 women will not survive 12 months after a hip fracture. So we as GPs are very focused on preventing fracture. So obviously menopause is a big issue for that, And exercise can help promote bone strength. It also promotes psychological well-being, obviously, and it can improve cholesterol levels. Now, the recommendation is 75 to 150 minutes a week, which is actually not that much exercise, even if you're in a busy, intensive course or job, but you just have to make time for it. There's no easy way about it if you're not an exercisey person naturally, Weight management is key. A lot of people carry a little bit of weight, and that's generally okay. But if you're obese, if your BMI is hitting the 34, 35, particularly, you need to do something about that. Because people with excess weight, particularly obese patients, do find that their menopausal symptoms, particularly the vasomotor symptoms, are much, much worse. And I can throw all the hormones in the world at someone who's carrying tons of extra weight. And until I help them achieve weight loss, I'm never going to get full control of those flushes and sweats. You can drink. There's no danger in drinking very moderately, but you've got to be careful that you don't let those units creep up, particularly for women, because we don't metabolize alcohol, a toxin, as efficiently as men do, as a rule. So less than 2 units a day is key. Anything more than 12 to 14 units a week is too much. And when you're at home and not going to a pub and you're pouring for yourself, it's very easy to find those levels creeping up. And I know a lot of women who through the menopause have increased their Pinot intake so as to get to sleep at night. And it does help in the short term, but it's not ideal. Smoking is not good for you under any circumstances. Neither is vaping. I don't have to tell you that. And even just reducing the amount of cigarettes you smoke without having the goal of stopping altogether can really impact outcomes in health. So and studies have shown that when a GP intervenes in a smoking person's attempt at stopping smoking, they have something like an 85% higher rate of success. So go and talk to your family doctor about smoking cessation. We've all been trained in helping with smoking cessation. If somebody does want to take alternative therapies, over-the-counter therapies, complementary therapies, there's absolutely no harm in most of them, but there are some ones that we worry about. Phytoestrogens. So these are plant-based medicines and extracts that have shown to have estrogenic activity in them. They often can help in the short term with menopausal symptoms, perimenopausal symptoms, but they are estrogenic in nature. So there's no reason to expect that they would have less negative impact on the body or more beneficial in the impact on the body than the tried and tested pharmaceutical grade estrogens, which we typically favor. Isoflavones, they're found in things like red clover and soya. We used to think that they would really help stabilize vasomotor symptoms. Actually, now studies have shown that they're the same as placebo, and the same would be true of lignans as well. Herbal remedies, you got to be really careful about. Things like ginseng, black cohosh, sage, some of them can actually show to have some forms of toxicity when used in excess. None of these things will hurt you if taken in the recommended amounts. St. John's wort, as you know, it has SSRI properties. So in Ireland, it's now a prescription-only medication under the name Pacifa, because not only does it have actual psychogenic properties, which are good, they're beneficial, but they need to be supervised. Moreover, it's a liver enzyme inducer, meaning a woman or a person taking St. John's wort who's taking other types of medication will have less of an impact from those other types of medication, say, for example, the contraceptive pill, because of the effect that St. John's wort has on the liver and the enzymes in the liver. So this is not something that should be used lightly. You need advice about that. Vaginal interventions, because vaginal symptoms in the menopause can be very, very unpleasant. Like even women who've escaped quite luckily without too much by way of sleep disruption and low mood and rage and all the other stuff, often find that the elasticity and the lubrication of their vagina starts to decline. So things like moisturizers and lubricants that have been specifically designed for menopausal women can really be beneficial. There's been some work using lasers in the vagina. Actually, I have a colleague in Blanchardstown who has a cold labor laser, erbium laser. They play with it themselves all the time, and they offer it to the patients at a certain amount of expense. It is certainly a safer product than the old-fashioned carbon dioxide, the CO2 lasers, which have been shown to be harmful in some cases because they're hot. They can burn the tissues. And then lastly, and the thing that I'm most concerned about is the upswing in people looking for what they call bioidentical hormones. These are forms of HRT, and they are in fact HRT, that are actually marketed by private compounding laboratories. So they're outside the normal checks and balances of the pharmaceutical type of medicines that we use. The products are unregulated, and while they may be very, very effective because they're often far more potent than what we use through the prescription process, they're not considered safer by any stretch. If you are going to prescribe hormones for a woman out of the MIMS, out of the compendium that we use, there are any number of examples of body identical or bioidentical hormones you can choose from. You most certainly do not have to go to an expensive private compounding lab online or wherever the heck to achieve these. And it's not supported by any of the European, international, British menopause societies do not recommend women avail of privately compounded bioidentical hormones. But many women will come to me to talk about hormone use because that's really what has been shown to be the most effective at improving their symptoms, okay? Now, some people don't want hormones, or some people are not allowed to take hormones because maybe they've had hormone-dependent cancers and they've been warned off by their specialist about using them, or they have other conditions that make using pharmaceutical hormones a little bit more difficult, But for a lot of women, it is the only succor they get. It is the only relief they have. If the whole reason we're feeling this off is because our hormones are peaking and troughing, putting small amounts of exogenous hormone into the blood as a tablet, as a patch, as a gel, as a vaginal insert will just flatten out those ups and downs and usually give almost immediate relief. And that's what HRT is, hormone replacement therapy. But there was a lot of resistance to HRT over the last 20 years, which is part of the reason why it's hard to get information from a GP on it now, because there was no demand for this. People just suffered in silence. And they were so afraid of the potential harm that could come from HRT, which has always been overinflated and badly described in media, that nobody was asking for it. Now, all of a sudden, people are particularly nice. The National Institute of Clinical and Healthcare Excellence in the UK has said, listen, people are suffering. They need to get their hormones in line. And there's no real reason why they can't try this stuff. Why is everyone so nervous to prescribe? And the main reason is breast cancer. So a study was done about 20 years ago, it was published, called the Women's Health Initiative, that implied that there was a slightly higher risk of being diagnosed with breast cancer if you were over 55 and if you had used hormone replacement medicines for more than 5 years. And there is truth to that, and I'm going to take you through that information in a moment. But what you have to understand about breast cancer is it drives us it causes a lot of fear for people with breasts. It is the thing we're most afraid of. Like I say to a woman, you're high risk for hip fracture. And it's like she don't care. But if I say you're high risk for breast cancer, she'll move heaven and earth to change that risk. It's the second most common cancer we'll be diagnosed with after melanoma. And about 3,500 women a year are diagnosed in the Republic of Ireland. Most of us will survive, thanks be to God, but a few won't. So it's a devastating diagnosis. Now, with early detection and treatment, survival is very, very high, much better than it ever was before. And there is a relationship between some types of breast cancer and hormones. Some breast cancers have hormone receptors on their cell walls, but HRT in and of itself, estrogen, progesterone, androgens, they're not carcinogenic. Like lots of stuff is carcinogenic. The sun is carcinogenic. Certain toxins in cigarettes are carcinogenic. There's nothing in HRT that's going to take healthy breast tissue and turn it into cancerous breast tissue. But if you have a breast cancer in your future, and sadly a lot of us do, there is a possible relationship between when that cancer will get diagnosed relative to how long you've used HRT for. So these are the data. Actually, that slide's a bit goofy. I'll use this one. You can have a look at it later if you want to. This is the information from the WHI study represented in pictures, okay? Now you have to remember that the WHI study was conducted in the United States. It enrolled women between 50 and 79 years of age. So a good handful of these women were in their middle to late 70s. It only used the horse urine hormone extract. I'm not sure if you're familiar with that product. It's called Premarin. And that word comes from pregnant mare's urine. And that is a cocktail of estrogens that comes from horses that has anywhere between 14 and 40 different types of molecule in it. And it's also taken orally as opposed to using it through the skin, which is what we typically do nowadays. So this was a very, very strong form of estrogen, which we almost never use anymore, given to quite elderly people. And we know as you age, your risk of breast cancer goes up and up and up. So not necessarily a representative group of the women who present to my surgery at the moment, but look at the data as it stands. A woman between 50 and 60 years of age, when she goes in for her mammogram, has a 23 in 1,000 chance of being told, oh my gosh, you better hang around. We got to take some more pictures. We think there might be something in there. Okay, so 20, remember that's 967 people in 1,000 will not get a breast cancer diagnosis, okay? If every one of those 1,000 ladies used some form of HRT for at least 5 years after her 50th birthday, that number goes to 27 in 1,000. So from 24 to 27. So sorry, from 23 to 27. So a jump of 4. Not statistically significant, but interesting and worthy of further study. Look at the relationship between being overweight, just having a BMI over 30 international units, okay? 30. So instead of 23 in 1,000, you're talking 47 in 1,000 risk of being told you have breast cancer in your 50s. That's more than double. And look at what a big glass of wine does every night. That's 5 extra cases in 1,000. So we're not trying to minimize the need for conversation around HRT and breast cancer. Of course not. We're trying to put it into perspective. And things like being heavy and having a big glass of wine every night, which don't cause people a moment's pause when they think about breast cancer, are far more likely to cause breast cancer stats to go up than using any form of HRT to improve your quality of life, prevent heart disease, bone disintegration, certain types of dementia, and most important of all, make you feel better. So according to NICE, we need to always consider HRT when a symptomatic patient presents, because there are some small risks attached. For most people, they're minuscule, and they're somewhat associated to the duration of exposure. So for people who go on HRT and use it for, let's say they're out their 40s and 50s and are thinking of kind of discontinuing in their late 50s, early 60s, which would be typical of almost all of my patients, the risk is absolutely minimal and much smaller, like we see. There was a concern about women getting a heart attack and a stroke when they initiated HRT in the WHI study, because remember, they were elderly women being given oral estrogen. Oral estrogen is thrombogenic. Oral estrogen goes through the liver in the first pass metabolism, and it activates certain types of blood clotting enzymes, which can actually promote events. So you're far more likely to get a DVT or a pulmonary embolism if you use your estrogen orally, and that includes HRT and things like the contraceptive pill. But we know now that if a woman is given estrogen in a non-oral capacity for HRT, either as a patch, a gel, an ointment, a spray, it avoids the first pass metabolic effect. It does not activate the thrombin system, and you do not have any increased risk of blood clots, heart attack, stroke over background. But now if the woman sitting in front of you has a high background risk, she's obese, she's smoking, she's hypertensive, obviously her risk needs to be addressed. But putting her on low-dose transdermal estrogen is not going to raise that risk. And there was a big consensus statement published by the British Menopause Society, just kind of reassuring us and comforting about that. So the very woman you would never give the contraceptive pill, say a heavier person who smoked, is arguably the very person who should go on HRT because it's cardioprotective, you know? Now that's easier said than done. They really should optimize their blood pressure. They should stop smoking and lose weight, et cetera, et cetera, et cetera, you know? Osteoporosis, I alluded to before, that's when the density, the mean mineral density of your bone starts to decline, and it really falls off hard during the menopause for women, for people with ovaries. More women die from complications of hip fractures, predominantly hip, a little bit vertebra, than all the uterine cancers put together each year. But the amount of kind of promotion and awareness doesn't seem to be as high as it should be. So it's really, really important that if you're high risk for fracture, and those would be people who smoke, who used oral steroids, who are sedentary, or who are very, very active, like say performance athletes, people who've used any kind of bone decreasing medication in the past, they really need to evaluate their bone health as they age. And HRT is both a promoter of bone density as well as a treatment for osteoporosis. So we often use HRT. In younger women, I would use HRT rather than say a bisphosphonate or Prolia or something to try to improve the bone mineral density before they get into their 50s. And that's the time of your life when generally things like the bisphosphonates and stuff come into their own. And then obviously trying to correct whatever the underlying cause is, you know. HRT works by promoting osteoblast activity. So you actually get new bone formation, which you don't typically get from things like bisphosphonates and Prolia. So just to finish off, it's very hard to diagnose the menopause. There are no serological tests for it, although a lot of GPs think there are. There's no blood test for the menopause. There's a blood test to say whether or not you've bled your last bleed. There's a blood test to say whether or not you need contraception in the future. But if you're getting those symptoms I mentioned, the flush, the sweats, the mood changes, the dryness, the sleep disruption, and you're in your 40s or 50s, guess what? You're in the menopause. And you don't need a blood test to diagnose that. So when women come to me in the surgery, they've already self-diagnosed in most cases. And I completely support that. Now, that doesn't mean I wouldn't do blood tests. I would sometimes check their thyroid if tiredness was a big feature of their symptoms, and maybe their hemoglobin as well, especially if they start to bleed heavy, as many women do in their 40s and 50s. We talk about why this is happening and what lifestyle modifications she could consider while she's waiting to see what treatments, if any, she wants. I like to steer people towards reliable online information because there's a lot of nonsense out there, as you can well imagine. Not every GP is as well informed about menopause care as they ideally should be, not only because menopause demand in general practice fell off a cliff 20 years ago, so we just didn't train, but also general practice as a whole is under enormous pressure at the moment. GPs can't retire, they can't take maternity leave because there's no one to replace them. And typically menopause consultations can be quite time consuming. So the more work you do in advance, the more you have your ducks in a row when you approach a GP, the more likely you are to have a successful outcome. Now, some people can be a little taken aback by the patient being more knowledgeable than the doctor, and that happens all the time. But you know, if you try to do it with kindness, you're likely to get a positive outcome. These websites I put together for you because I find them really, really beneficial. So the Primary Care Women's Health Forum, PCWHF or something it's called, is a UK site. Most of these are UK sites. And that is a charitable organization that the National Health Service funds. And everything on there is gold standard. It's peer reviewed. It's extremely reliable information. There's a private doctor called Louise Newson in the United Kingdom. She's a GP like me who just devolved into menopause care. But unlike me, she's a real entrepreneur, and she has got 40 doctors and nurses working for her across the Midlands in the United Kingdom. I think she herself is based in Stratford. And she is the menopause private specialist of the UK, basically. She's the most well-known person. Davina McCall interviewed her, all of that stuff. Well, what's nice about her is she has a website called menopausedoctor.co.uk. And with the greatest of respect, she makes a nice profit, I'm sure, because I know her private consultations are like 300 pounds sterling. All the information she has to hand, she puts for free on that website, and she has a patient page and a healthcare practitioner page. And she, she and I kind of chat on Zoom from time to time, and she's really, really supportive. So I have great respect for Louise. The Women's Health Concern is the patient arm of the British Menopause Society. So I'm a recognized expert and trainer for the British Menopause Society, and we put information together for our patients on that website. And then menopausematters.co.uk is just a private site. It's a charity, and it's run by a buddy of mine called Heather Curry. She's a professor of gynecology up in Glasgow, Dumfries, Glasgow, and she's a pet. And she was the past president of the British Menopause Society. And again, she tries to empower the patients by putting as much information free online, good quality information as she can get. So I'm going to stop my slide, stop my share. Thank you for your attention. I was hoping to